My name is Andrea Cronrath. I'm out of Spokane, Washington, and I am here. Today I'm discussing Syphilis Masquerade, a case of demyelinating encephalitis actually presenting as neurosyphilis. So a little bit of a spoiler there. So I don't have any disclosures to report. And today my case is, first I'm going to start with an introduction, then a review of neurosyphilis and MOGAD, then talk about syphilis testing, disease management, case conclusions, and of course, the big point, the learning and the takeaways. So our case begins with a 19-year-old female with no past medical history, and she presented with subacute progressive lower extremity paralysis and areflexia, actually from an outside hospital. I was on the night team and we got the call for the intake. It had heard that the outside hospital had gotten an LP as well as an MRI. The LP showed lymphocytic pleocytosis, and the MRI showed this. So it showed T2 hyperintense foci diffuse throughout the entire spinal cord, thoracic spinal cord, the brain. Her vitals were normal, and neurology was consulted, obviously given concern in the read for infectious, demyelinating, autoimmune, or paraneoplastic syndromes. In addition, additional history was gathered, and she's a young college student who had quite a bit of sexual contact and exposures without use of a barrier protection. And so there was concern about syphilis actually in this region. And so an RPR was gotten by neurology, which showed a titer of 1 to 8. So that kind of leads to an aside of, oh, where are we at? What are we thinking about? And so a review of neurosyphilis and RPR. So neurosyphilis can occur at any point in the clinical stages of syphilis, whether that's primary, secondary, latent, tertiary, and is notoriously challenging to diagnose because of the wide variety of symptoms that individuals can have and present with. Specifically for this patient, an RPR was obtained given the question of syphilis as, is this a fast test? And it usually gives us a general idea of how positive one might be. And so just to review actually what an RPR is and why it's sort of fraught with error. The testing actually involves charcoal particles, and it's reacting against those antibodies, IgM, IgG, against, in this case, syphilis. And then it's put on a carbon paper, and if it agglutinates and reacts, then it's deemed as positive. And as they're going down the paper, there are less and less serum or in each sample. And a negative, when there's a non-reactive test, is negative. And at that point, you know how rapid your titer is. For this patient, actually, she ended up having a surprise. So we were treating her for meningitis. She was on high-dose steroids, and we obtained an encephalitis panel. It was negative for MS, but positive for something called anti-myelin oligodendrocyte glycoprotein antibodies. And that is specifically an autoimmune attack on the oligodendrocytes. And this is an immunohistochemistry, not her, showing this layout at the actual cellular level. Now, MOG antibody disease is extremely rare, but is becoming more and more prevalent, especially with the testing that we do. So for her LP was sent out, and we got the results back from Mayo. It's becoming more and more common, especially in the Americas and in Asia. And the question here is, why the confusion? You know, syphilis, autoimmune encephalitis. Well, there is lots of case reports out, especially for syphilis, and it mimicking other things. They both cause lymphocytic pleocytosis on LP. They actually have similar patchy findings, often on MRI, that can really be anywhere. And they both can present just with varying neurological complaints, depending on where the infection is or where the autoimmune attack is. And false positives are common. So specifically the RPR is a great test, and we use it often. And there are other testing, and they're all kind of fraught with some kind of error, which is why there are changes to how we standardize treatment or assessment for syphilis. Even something like a recent immunization or pregnancy can cause a false positive, actually. And particularly the RPR is notorious. And why we care? Well, the management is very different. For neurosyphilis, we need to be on top of it. We need to treat it. It is antibiotics, and it is a long course of antibiotics, versus MOGAD is actually high-dose steroids, maybe IVIG or Plex. So for this patient, she was given 5 days of steroids. We ruled out meningitis, ruled out all the other things. We did additional testing for syphilis, all negative, and she did wonderful. She followed up with a specialist and actually wasn't even given disease-modifying therapies because of the singular attack. So that leads to the learning points and takeaways. And so really, when in doubt, we need to be treating. There's a high incidence of false positives, but we cannot be missing neurosyphilis and syphilis, especially with the rise. And for MOGAD, it actually has overlap with MS symptoms, and it can be difficult to distinguish, but it is important because the overall treatment course varies. This is my last slide, actually, just showing that since 2015 or 2013, we've had a 700% increase in syphilis diagnoses. And that number seems to be plateauing, but it's still extremely prevalent. So we need to be on top of it and empirically treat when in doubt. I can take any questions now.
Great, thank you so much. That was fantastic. And indeed, we are seeing more and more syphilis. Always a good reminder to think about the great imitator. We have a couple questions, which I think you've already partly addressed. You might just clarify just a little bit. So one of the questions is in regards to the diagnosis of neurosyphilis, where in the past we were taught you need you need a TAP, you need CSF to check the VDRL. And is that still the definitive diagnosis for neurosyphilis plus symptoms?
That is a great question. So the question being, again, what do we do for neurosyphilis and what is the best testing? And it is truly the best testing is the CSF. And actually I have a slide here. Let me go down. Let me pull it up. Oh, here. It's our kind of our algorithm for syphilis screening. This is more in the serum. It's confirmatory test you do need to use the CSF, and typically it is the VDRL, but there are other ways, and often it should be positive in the serum too. So you should be doing either the traditional or the reverse algorithm for screening and testing whenever you have any concern. So it's kind of an all of the above, and when in doubt or when you're concerned, you should be just empirically treating if you have any level of suspicion. But it is a great question, and it is still fraught with error.
Thank you. And then another question, I think just a little bit of nuance you'll add to this. So in this case, you allude to that you did other testing to confirm that it wasn't neurosyphilis. Maybe if you could just address that briefly. And then also, is it possible that syphilis could have been a trigger or could be a trigger for MOAC?
Those are great questions. So what other testing did we do? And then is it a trigger? So to answer the second part, yes, it could be a trigger. Actually, there's some research, although it's really hard to test such a very rare disease, that any kind of viral infection, and for her, actually, her EBV IgM was positive, and there's a question of if that's what set her off. Any infection, including viral or bacterial, can be a trigger. And so there's always that thought of, is that potentially what caused this? In addition, I actually have a slide here, which the other question was, what other testing did we do? Let's see if I can pull it up. So we actually got the RPR, we got a treponemal antibody, we got VDRL of the CSF, and then we also did a special send out test, just confirmatory testing, because again, there's non-treponemal and treponemal testing via the antibody and sent it in via the serum. So all of those were negative. That was all very reassuring. And this patient actually didn't get empiric treatment because she had a penicillin allergy, a severe one. And so we were discussing transferring her to the ICU and ultimately decided to, while we were doing that process, we got the other results back. So she didn't actually get treatment. It's one of those rare cases where we didn't empirically treat, given the other risk factors.
Wow, thank you. That's excellent command of the case. You can't see everybody giving you an applause, so I will be the one to do it on camera. Thank you so much.
Thank you. Yes, no, thank you so much. I really appreciate everyone's questions, and have a good rest of your day.
Thank you.